So who is this? This is you. This is soon to be you guys. So these are some things that we look for in a BHC. So this is someone who knows how to do brief assessments in 15 to 30 minutes and how to do brief behavioral interventions as well. You may be thinking, well, I don't know that yet. You will know a little bit about it by 7 p.m. You will. You will. Being familiar with the primary care way of seeing patients. So when I say primary care way, I'm saying fast-paced. They see a lot of patients. In pediatric practices, it's very common for them to see about 40 to 50 children in a half day for one pediatrician. They are moving through visits. So one person can see anywhere from 80 to 100 children in a day. So it's a lot.
Is that an 8-hour day, or is that one of those,
It's
like 16-hour days?
8 to 5.
Wow.
8 to 5.
That's insane.
It is.
That's
It is.
insane.
Any idea? So to build off of that, any ideas on how long the average PCP visit in the U.S. is? How many minutes? 5 to
10 minutes?
5 to 10.
They're saying that many,
15.
5 to 7?
5 to 7. So 7 minutes is the average visit. Depending on where you are, they may get 15. It's very rare. If you're in a regular up and running practice, you don't get 15 minutes. In residencies, you do, because they're learning. So we give them 15 to 20 minutes with their patients. So 7 minutes. 7 minutes. So you obviously cannot address more than one thing, if you think about it, in 7 minutes. So this is where, again, a lot of things are missed or undertreated because they literally don't have time to do it. So this is where you can come in to help them deal with these things that they're missing. Works as a partner for the whole panel of patients. So the biggest thing in primary care is that we don't have caseloads. That word caseload goes out the window for primary care because the patients that I see, it's the whole practice. The whole practice has access to the behavioral health consultant. Anybody at any time, if they're a patient in the family health center, they can come and ask, can I see the BHC today? They can see me today. They can see Zeke today. They can see Pooja today. They can see Beverly today. We have patients who do that, who will walk in and just say, can I see the BHC? I need to ask them a question. Or it's usually my cousin comes here and they told me you guys have a BHC. Can I see them too? Is usually what happens is they have family who are part of our practice. So you work for the whole panel. Our goal is to treat the whole population. So that's why our visits are briefer. So we have a greater reach. It's provide a low impact intervention to a high number of patients, whereas specialty mental health provides a high impact intervention to a smaller amount. That's why you have caseloads in specialty mental health. So that's one of the big differences between the primary care way versus specialty mental health. And then this one, PCPs will love this. You can help them relieve some pressure off their schedule. PCPs have what they call the heart sync patient. Does anyone know what the heart sync patient is? Anybody heard of that term before? You may have the heart sync patient as well, especially if it's a patient that you know really well. This is the patient when you're happy, or you're walking into clinic to do your practicum, and you're looking at your schedule for the day, and then you see that patient. And then you take a deep breath, you say, oh my gosh, that person's coming in. I get so frustrated when I work with this patient. That's the heart sync patient, where your heart just sinks in your chest because they're quite complex. And maybe you feel frustrated. Maybe you feel that, gosh, I've done everything I can do. I don't know why they keep coming back. I don't feel like we're getting anywhere. So they need help. They have heart sync patients too. And they need help with this. And so you're the ones trained in humans and how to work with humans effectively. And so they need your help on how to work with the heart sync folks effectively. Because what happens is they want to get this person in and out. They don't want to deal with this patient because it's too much, it's too hard. And so that patient might get shortchanged in their visit because the PCP just doesn't want to deal with this. So this is where you could come in and help let me go in first. Let me go in the room first. Let me talk to this patient. Let me see why they're here. Let me see what I can do to smooth the waters a little bit. And then I'll come back and tell you what they're really here for. And so they like that. So you can help them with their more complex patients so they can be more effective. They can move faster. Because what happens is the heart sync patients are the ones that take all their time, make them behind in their schedule. So they really don't look forward to this. So you can help. You can help with this. So this is, making sure I'm good on time here. This is a way to remember what your role is in primary care. Gather. You're a gatherer. That's what you are as a BHC. These are the things that you do. You're a generalist. You're easily accessible. You're team-based. You're highly productive. So what does that mean? Typically in this approach to care, because we have shorter visits, because we're seeing the whole primary, that's our panel, I guess, is the whole clinic, is that you'll see a few more patients than you would. You may see anywhere from 8 to 14 patients in a day. That's fairly common, would you say? It can wax and wane a little bit, but that's typically where it sits. You're an educator. What do you think I mean by that? Who are you educating? The patient and the staff. What staff? Who are you helping? Everybody on the team, yeah. The doctors, the medical assistants will definitely come to you and for help. The nurses may come. The front desk may say, we have this patient that just curses out the registration every time they come. Can you help me? Can you tell me what to do so I can help de-escalate? They may just come to you to ask for some tips on what to do to help de-escalate hostile individuals. So you're educating the whole team, And this can be done informally through, come over here, I'll talk to you. Let me tell you how to interact with this patient better. It could be a little more formal as like a lunch and learn. Maybe you want to educate the staff on how to work with parents more effectively, how to communicate with your patients more effectively. So however you want to do that, you have some wiggle room there as an educator. Your routine, so it's a regular part of care. What can happen sometimes, patients who have had a negative experience with behavioral health is that you walk into the room and you'll say, sometimes what happens, hi, I'm so-and-so. People slip up and say, I'm a therapist or a counselor. And that the walls get put up really fast, especially in our clinic. That patients do not want to talk to a therapist or a counselor at all. But if I use the word consultant, and then I'm here to help you work on your health better, I'm here to help you manage your stress better, it sounds more a routine part of care. Patients may think you're singling them out. Well, why are you seeing me? You do this with all the patients? I've had somebody. This happens from time to time. Well, how come you're singling me out? And so we'll say, we see all the patients who come into the clinic. We offer this service for every patient in the Family Health Center. It's just something to help you deal with your life a little differently. And so anything that you can do to make it more routine, your patients and providers will appreciate that. And then the care structure. I'll talk about consultation in just a little bit here. That might be teeny tiny. It probably is. But this chart basically shows the differences between behavioral consultation on one side and then what's happening in mental health clinics on the other side. So you can see that the biggest thing is that we're population focused. We're focusing on all of primary care. Whereas in specialty mental health, it's very patient focused. You're focused on the patient or client who's sitting directly in front of you. And then I won't bore you with reading through every single thing, but essentially, this base helps you map out the differences between the two approaches to care and how. I'll focus on this one. Where is it? Primary customers. So what do you think about that? In the primary care behavioral health model, the primary customer is the PCP. Then the patient is second. It's a little different than what people are trained on, whereas you're maybe trained on is the client, then everybody else, or the patient, and then everybody else. But as a consultant, my role is to help my PCP. My role is to help him or her get through their schedule without pulling their hair out. My role is to help him or her treat the conditions they're usually ignoring because they don't feel comfortable, they don't feel competent, or they say, I don't have time to deal with that, is what they'll say. So my role is to help them feel more competent. Then the patient benefits, because they get the services from us, and their PCP feels more confident, hopefully in the future, to deal with some of these things on their own. So Zeke, I'm going to put you on the spot again. Have you, or what differences, I guess, have you seen with providers, maybe at first, being a little hesitant to treat behavioral health stuff? But then by interacting with you, have you seen that help them feel more comfortable? Does it matter, less comfortable? What have you seen in clinic?
Yeah, no, absolutely. And we have it, it's nice because it is a residency clinic that we kind of set up where they get to train with us, alongside of us. But I think a lot of times it's again, just kind of that ignorance or that lack of awareness. Like, okay, I have this person, like, what do I do? What can I do? What are my options? Like,
Yeah.
And a lot of the interventions and things we're going to talk about today can be relatively simple or can be done quickly.
Mhm.
And so I think even just them knowing that they have some type of go-to or even one little thing that they can pull out of their pocket, that it definitely feel a lot more comfortable.
Sure. And my hope is that you guys will get to see that at your sites too, especially providers who are a bit standoffish on anything behavioral. That knowing that I have somebody right outside the door that if I get stuck, I can step out of the room and say, hey, can you help me with this? I thought I was assessing for depression, but I said something and now they're mad at me or something. Can you help me? And so the fact that you're right there versus down the road or in another building, they'll feel a little more comfortable. And you hopefully will start to see them addressing things first. At least that's what I've seen over the years, is that PCPs will step out and say, well, I already gave them the PHQ-9, and actually it was an 8, and actually we talked about it actually wasn't depression, it was just stress, and I gave her some relaxation skills. They'll start to do this on their own and feel really good about it. So then they can help you, they can send you some things that, okay, I tried relaxation, it didn't really help, I need your help with this. So the hope is that they'll start to do some small first line things first, and then if that doesn't work, they can come for you guys for some help with these things. Okay. So why be brief? Just as an overview, we've hit on some of these things already. I'll focus on this one. Has anyone heard of a vertical versus horizontal focus to care? People heard of that before? There's just another way of looking at primary care versus specialty care. And any specialty care, so not just specialty mental health, but cardiology, pulmonology, any specialist. So vertical care is, I see fewer patients, but provide more intense treatment to them. Whereas horizontal care is, I see a ton of people, but provide a lower impact treatment to them to see if that will help keep their symptoms appropriately managed, keep them functioning, where they feel they can do things in their life. So that's really what primary care is more of a horizontal focus. Okay, this is kind of a lot to see, but I promise this is close to the last slide, then I'll give you a break. This is a sample flow of how patients get to you in primary care. This is not the way. There's many different ways. This is assuming that the BHC is brought in by the PCP after the PCP has seen the patient. So what we call warm handoff, you might have heard that term before, where the PCP is handing off the patient to you. They've done their part. They need your help. There's many instances where they may tell you, hey, I'm behind in my schedule. Can you go in there and see that patient for me first? Maybe in the reason for visit it says they're here for uncontrolled diabetes. They're here for substance misuse. So they're like, can you go start and then just tell me what you did? So sometimes you'll go in first, but essentially this one is the opposite. And so there's two routes. The first one is you do the face-to-face consult. And then the other side is, say if you're not there, they may do a phone contact. They may just schedule a consult for you to see the patient later. Or it might be they just need to know where are the bereavement support groups in the community. They just need a community referral or a referral to a psychiatrist. So hopefully, this gives you at least a nice picture of what it could look like. Later this afternoon, we'll go into detail of what the actual visits look like. We'll watch some videos so you guys can see some examples of what this looks like from the time the PCP brings the BHC into the picture, all the way to the end when the BHC goes back to the PCP and tells them, well, this is what I did, and this is what the plan is for the patient going forward. Okay, we're gonna skip that one, because I wanna wait till the end for that. But before we take a break, are there any just general questions that people have? This was just to give you a broad overview before we get more specific on the ins and outs of consultation. But any initial questions or things that you all want me to address later this afternoon?
I asked like not questions, but
Oh,
I'm
yeah.
just curious, like general reactions or responses. You know,
Yeah.
I've talked
Oh,
about
sure.
this throughout, but you know, it's like I think we all entered this program to varying degrees with like, okay, this is what I'm gonna be doing in this pitch program, and this is integrated healthcare. So I'm just curious, like
Yeah.
some responses to this information or your reactions to what
Yeah.
Dr. Osai has
Yeah.
presented thus far.
I think it's cool, really cool. My one little thing, for whatever reason, I can't get over it, is that I'm serving the PCP, which is just me shallow, I guess.
Sure. Well,
I know, and I'm assuming it's because he is so into this integrated approach, so that's my only little,
yeah.
does that make,
No, that's fair. I hear that a lot, so this is not the, it's common. I think the biggest thing to remember, and I think at least what helps me understand this, is that primary care for many decades has been very deficient in how they do behavioral health. They've either not treated folks or they've undertreated them, as you said. Take this antidepressant and that's it. I'm not going to tell you how it works. I'm not going to give you any other options. Just take this and come back and see me in 2 months. And so the reason why this approach came about, this is a grassroots, clinician-driven approach to care. And so this came about by some behaviorists saying, we're tired of seeing primary care do this wrong for so long and not do this as well as they could be. It's coming from the idea that primary care is okay, but definitely not where they should be in terms of treating the whole person. They're just treating, I'm gonna treat this part, but I'm gonna ignore this other stuff, even though this other stuff is affecting this. And so this model comes in to say, let me help primary care. So I should rephrase that and say, you're a consultant of primary care. So everybody, not just the PCP, definitely the PCP because they're treating the patient, but to the nursing staff, to the medical assistants, to primary care in general. You're there to make it better, is what you're there for. So hopefully that
yeah, I'm sorry.
helps a little. No, don't apologize. That's good. Yes, ma'am.
Just to make a comment on her, but then my reaction, with that was, I kind of say like would be working behind the curtains kind of thing. Like we, you know, I mean, we're helping primary care is still primary care, that people are still wanting to see the doctor.
Yeah,
But we're still behind the curtains, adding to the play.
absolutely.
To make it work, kind of
Yeah,
thing.
that's really good.
That's
You should write that up somehow. That's really good.
But, so
Yeah,
I'm
that's
excited
really good.
about it.
Yeah.
But it's also kind of scary because it is a different setting for what we've been taught in this program.
Sure.
I mean, it is very like, okay, 15, 20 minutes. And to me, it's like, what would be challenging is, what if in those 15, 20 minutes, the person told me things that I'm like, okay, I need more time.
Mm-hmm.
This is not like a 15, 20 minute thing.
Yeah.
So where do I go from there?
Sure.
It's just like, okay, this person needs more than
Sure.
15, 20 minutes of my time.
Okay.
That's what's scary.
Sure. Primary care providers say the same thing. It's not just behavioral health. Believe it or not, patients tell their PCPs what they tell you. So sorry to bust your bubble, behavioral health folks. They talk to them about being suicidal. They talk to them about being raped. They talk to them about everything that they already tell you. And so PCPs say the same thing, I need more time. I need more time with them than my 7 minutes that I get. So the nice thing about primary care, it's longitudinal. So they're seeing patients sometimes their whole lives. And so the nice thing is that, guess what? You can bring them back again. You can bring them back in a week, 6 months, every year, however you need to. But that's the nice thing is that it doesn't just end at the end of your consult. It could be, can I see you again in a month when you're seeing your PCP? Let's follow up with this. Can I call you tomorrow to see how you're doing? It's all relational in primary care. And so, yeah, sometimes 15, 20 minutes isn't enough. A lot of times it is. So it just depends on what you're addressing.
Well, I really enjoy fast-paced work, so I'm really excited to do this in a fast-paced setting and
Okay.
getting to see like what that's like and be able to help as many people as I can instead of just these long 8-year
Yeah.
sessions.
Absolutely. And again, it'll make more sense once you see it, once you're at your sites. I mean, we could talk about it all day, correct me if I'm wrong, but until you're actually in the clinic doing the work, it's like, whoa, you're like, wait a minute, this is not what was in the chapter that I read. It's not supposed to happen that way, but it happens that way. But that's okay, we'll work with you, we'll make sure that you feel flexible to deal with all the things that come up in primary care. Yes, ma'am?
I just have a documentation question. So I know that you have medical assistants to do the documentation and stuff. Where will we fit in as far as documenting what we see and
Yeah.
what our treatment is?
You will be in the same EMR as everybody else. So anything that you write, everybody sees. That's why you gotta be careful how you write your progress notes, because it's in there, it's a legal document, so patients can request the records and see what you put in there. Same thing goes with it, we tell the PCPs all the time, please be careful with what you're writing in the note, because patients can see that. So you'll be documenting in the same EMR as everybody else on the team.
We'll be able to see our recommendations now.
If they say go to medical records and request it, if they want it for legal reasons, maybe.
So like we'll be adding on to what is already filled.
You'll be creating a new note,
You'll be creating new.
a brand new note. Absolutely.
So, I was kind of curious to talk about behavior consulting in like group setting and
Uh-huh.
group setting. So is that how our group hours are being taken care of?
Possibly. Yeah.
Yeah, I think that's a good answer,
Yeah.
possibly.
Mhm.
And so, I'm gonna go with.
I was like, I'll defer to them for that.
Remember that we don't need, there's not a requirement for group hours in internship, no, it's not the same as practicum. So it's not like you have to have this many group hours, so, yeah. And again, we're sort of putting a whole new model, so I think I think one of the things you're seeing is the word patient and consultant, rather than counselor and client. So how we're used to practicing, say, in the Sobriety Center, I mean, this is very different. So even the way we're gonna have to look at hours, and this is new, remember I said Maverick? So as you're looking at education class, we're gonna get a lot of information from y'all this semester on how it's gonna fit into like our internship. I have no doubt that you will meet your hours, but there won't be like a
Definitely
requirement.
will.
No doubt with this longitude.
Oh my gosh, yeah, there's so many of those. Yes.
So, going back to documentation,
Uh-huh.
and for those of us who are supervising
Mhm.
the behavior consultants,
Yes.
do we put our notes in there too? And
So
Is that different?
you'll be co-signing notes, that's it.
oh, that's it.
That's it. There's
Okay.
nothing else that we'll have to go into there.
That we got it easy.
Yeah, now, your supervision notes, how you
Yeah.
keep those are like in a
That-
Word
that-
document,
yeah,
that's
that's
different.
here.
Yeah.
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 Right.
No,
You
no,
gotta
no,
do
I get
something.
that, but what I mean is, are we putting it into their system? and-
No. Supervision notes are separate, just you'll be reading their notes, essentially, hopefully, reading their notes. These are great questions, and again, please ask questions throughout, at a break. I'm happy to answer whatever it is, the questions that you have. I just have a few things to show you, but then I'll give you a break here. These are some really good books. This one we'll be using for the class next semester, along with a different book, not this one. This one will be for those of you who take course 2 for integrated care. I'll be using this one. So this book just talks about the overview of behavioral consultation, how it came about, how to do it, the ins and outs of the nuts and bolts, the things that people really want to know. What does a visit look like? This book that I'll use in the second class is really focused on interventions. How do you treat patients with diabetes in primary care? What am I supposed to do? How do you treat sleep, obesity, all of these things? So that's what this book will cover in class 2. And then this book, I just added it in there. It's really nice. It's a book that was written for primary care providers, but it really benefits behavioral health too. So I don't know if folks are familiar with Acceptance and Commitment Therapy, ACT, or Fact-Focused ACT. And so this book is built on the premise of ACT. So Patty Robinson, Deborah Gold, and Kirk Strassel put this fabulous book together that talks about how do you use ACT in primary care settings. So even if you haven't been trained in ACT, I'll introduce ACT to you in the second class, but it's still worth the read, and it gives you how do you deal with the real complex patients in primary care who have trauma backgrounds on top of type 2 diabetes and blood pressure and their heart failure, and they're on the verge of homelessness. How do you deal with those patients to help them through? So this is a really good book that I would recommend purchasing at some point in your life. Patricia Robinson, Deborah Gold, and of course Kirk Strassel. He's the co-person for developing ACT, so Kirk Strassel. I promise I'm gonna give you a break. One last thing. In your folders, there's a handout that talks about some upcoming presentations in January. Patricia Robinson, we have the pleasure of bringing her to UT in January to give 2 grand round presentations. The first one's in the Department of Psychiatry, and she's going to talk about clinician resilience. How do you manage the possibility of burning out of what you're doing? So she'll reference this book in that talk, and then she's going to speak to the Department of Family Medicine the next day. So those are free. Those of you who need CEUs, you can get CEUs for those too. But I'd highly encourage, if you haven't heard Patricia Robinson speak, I'd highly encourage you to come. She's a fantastic person and just a great speaker, very well respected in primary care. She's also the co-developer of the PCBH model. I'll talk a lot about her. But definitely come if you can. And we'll take a break. So let's take 10 minutes, come back at 2:55.